First of all, I just wanted to say that I'm not a doctor yet. Hannah and we're both on our way, not quite there yet. Both of us did complete our master's degrees down at Minnesota State Mankato, though. So we do come in with our master's degree and both on our way to PhDs in clinical psychology. Um, Boy, I'm just reading through the comments here, and what a great representation of different fields across looks like North Dakota, South Dakota. I saw excellent turnout. I'm happy to see so many people interested in this topic and taking some time out of their day to hear a little bit about age-related microaggressions. Hannah, if you want to advance the slide.
Yep. I already did the pre-test, so we'll go
Sure.
ahead. Here we go.
Yeah, so we do have a number of objectives here with our time today. We want to provide definitions of ageism, definitions of microaggressions, but also want to explore the relationship between microaggressions and ageism that occur at the micro level in the form of what we're calling age-related microaggressions. Uh, because age-related microaggressions really are a new concept derived of two older concepts, we'll kind of talk about the state of the literature and where we're sitting with it right now. And then we have a few case examples at the end in which we'll go through that, and then we can provide additional resources kind of throughout if anybody has any questions. Otherwise, we can get our contact information out as well if anybody has any follow-up questions. Next slide, please. All right, so we'll start the conversation with ageism, and please, I can't see you guys, but feel free to interrupt at any point if you have any questions or if something I said doesn't make sense. But ageism is not a new topic. I'm sure many of you are aware of that. But the stereotypes, discrimination, prejudice related to older adults has likely been a social issue since humans started walking on the planet. Um, in fact, if you look at the Bible, even there's passages throughout that kind of do have ageist undertones to it. So it'd be interesting if you wanted to take a look through that at some of our really early literature. But the earliest published literature that really explicitly discusses ageism dates back to 1969, and this was an American psychiatrist. His name was Robert Butler, and he published a paper on ageism where he stated that ageism really is another form of bigotry and defined it, as you can see on the slide here, as prejudice by one age group toward other age groups, a deep-seated uneasiness on the part of the young and the middle-aged, a personal revulsion to and distaste for growing old, disease, disability, and a fear of powerlessness, usefulness, and death. I mean, that is a dark definition, you guys. Very dark. Um, but really, this is the earliest definition that exists in the literature. And he just continued to discuss ageism through a number of publications. And he later built onto his definition a bit by stating that it's a process of systematic stereotyping of and discrimination against people because they are old, just like racism and sexism accomplish this with skin color and gender. So over the years now, since 1969, ageism obviously has been investigated. It's been researched and it's been defined a multitude of different ways, and largely has been expanded in how it is defined. Next slide. So in 2009, and this is still, in my opinion, the best concept analysis on ageism. 2009, there was this concept analysis that was completed on ageism as a construct, and they searched all published literature through a variety of different databases, and they examined ageism. And they then looked only at literature where ageism was originally defined. So papers that cited other papers were excluded. They just wanted to find those original original definitions. And what they found was 27 different definitions of ageism that were somewhat different over the 40 years between the 69 and '09. Um, and they used those definitions to create a very modern, well-rounded, in my opinion, definition of ageism. And that's what we see here on the slide. So I'll just read that. Ageism is defined as negative or positive stereotypes, prejudice, and or discrimination against or to the advantage of elderly people on the basis of their chronological age or on the basis of a perception of them as being old or elderly. Ageism can be implicit or explicit and can be expressed on a micro or macro level. So much more broad than that original 1969 definition, but impressive the holding power that 69 definition had because there's a lot of similarities. Next slide. Let's see here. Okay, universality of so what do we know about ageism? Well, we have a definition now, and we do know that research consistently finds that older adults are almost unanimously reporting that they have experienced ageism in their lives, and younger adults, interestingly, very freely admit to holding ageist stereotypes and even having committed an act that was ageist in nature. Unfortunately, compared to sexism, racism, some suggest that ageism is so just pervasive within society that it's almost entirely socially condoned. It's one of those isms that's very much regarded as not a problem. Um, Although people that work with older adults I think, better equipped to recognize ageism as harmful. Ageism really continues to be considered largely normalized and pretty acceptable behavior. And one ramification of that is that researchers may tend to overlook it as the problem that it is. Next slide, Hannah. Talk a little more, I think. Yeah, great. So ageism as a problem. It is a problem because there's a multitude of negative behavioral, psychological, and cognitive consequences of ageism that have been studied for a long time. A 2020 systematic review research examined, oh, how many? Let me look at my notes. 13,691 papers. That's an incredible amount of literature. Looking at health consequences of ageism. And throughout those papers, it included, oh, what was it here? Over 7 million participants when you aggregate the data, 7 million older adults. And the findings indicate that ageism led to worse health outcomes in 96% of those studies. So it's well established that this is a problem. And examples that they found in the literature can be seen on that right-hand side there. And those are in order in terms of how often and how strong those relationships were. And by and large, being denied access to health services and treatment was very much an outlier in terms of being the most common form of ageism. So if we think of that, it's like, okay, well, why might that be? I know for me, I hear a lot of stereotypes about, well, becoming more depressed as an older adult is just kind of part of the aging process. There's less to be hopeful about, so depression can kind of be expected. The normalization of cognitive decline is largely seen, and while some of that is true, some of it is not. Pain, people talk about pain as just being a part of growing old. Um, I'll often see referrals talking about how a case is just too complicated, so they're going to pass the case on to somebody else because older adults, as people get older, they do become more complex medically. Um, and another one that really gets me is when I hear we don't take patients who are on Medicare because the Medicare reimbursement rate is so much lower. These are all very ageist. I mean, can you imagine if we had those same types of stereotypes about other marginalized populations? You know, it would not be seen as a non-issue. Um, go to the next slide, please, Hannah. Okay, so let's break down ageism a little bit more. If we consider ageism and its various manifestations, we can really think of it in terms of micro levels and macro levels, similar to that Iverson concept analysis definition. Um, and macro would be instances kind of like the ones I've described where a facility, an outpatient therapy facility, won't take Medicare patients. Other instances of mass kind of discrimination based on age, forced retirement ages come to mind. Hearing more and more, and I'm not trying to turn this into a political thing, but more about age limits when it comes to holding presidency. I'll try to stay off my soapbox. But other examples include like setting upper bounds on age limits in clinical research. I see that quite a bit, where it's like we're going to take adults, but we're not going to take anybody in clinical research that's above the age 65. And then I think we can all relate to macro level form where we see older adults being kind of patronized in the media, kind of using older adults as comic relief, oftentimes in the media, just other forms of ageism. Uh, these are largely malevolent forms of ageism, but we should also remember that this can also be broken down to a more benevolent flavor as well. So bearing that in mind, if we think of like at the macro level, a more benevolent flavor being this assumption that older adults are wise. They're all wise. They're very highly moral. We'll see and hear people talk about the golden years, especially in the media. And this assumption is really it's just clumping all older adults into one group. The underlying stereotype really is with this golden years example of gaining membership into the older adult population kind of equates to retirement. Well, we know not all older adults are retired. Um, there's this idea that being an older adult is universally serene or carefree. You know, your kids have been launched. You can do whatever you want. Really negates and invalidates the diversity that really exists within this demographic in terms of, you know, socioeconomic status, health status, disability status, what family dynamics look like, you name it. Um, so important not to overgeneralize at the macro level. Um, Macro, I stopped there because that's not really the focus of this presentation. And it's fairly well studied, fairly well established that macro level forms of ageism exist. But I think it's important to note that, and maybe the figure should be manipulated a little bit, but I really feel that the macro level forms kind of predict micro level interactions, micro level forms of ageism. And this is where we kind of start to get to this crossroads with this other concept, which is that of the microaggression, which is further broken down, as you can see, into these three different forms. And we'll get into some of that with some of the research that we talked to. Next slide. Okay, this one, I won't belabor this point, but some examples here of micro level manifestations of ageism that at least have been mentioned in the literature to date. Most common, I would say, is probably the most common that we'll see in the literature is typically on elder speak. If you're not aware of elder speak, the definition is fairly simple. Adjustments of speech patterns when talking to an older adult based on, of course, chronological age that you know or the perception of an adult being an older adult. Uh, should be, I should note here, this is an opinion. This is not based on any fact, but I think by and large, elder speak is largely well intended. It's socially informed, and I feel like it's a habit. Um, Providers, physicians, social workers, people working at checkout counters. I don't think they're talking more loudly, more slowly, or enunciating more fully to specifically be mean toward an older adult. I think they do it because of this stereotype and a set of assumptions that's been elicited, that's been triggered by their own perception of this individual and what they expect an older adult to look like. Um, so if I think of like what this might look like, I would say, okay, well, hey, here's what I am considering an older adult in my presence. And being old means, in my opinion, in my stereotype, that there's an increased chance that this person might have poor hearing. So I should speak up, and maybe I should speak a little bit more slowly. Well, and maybe I should really enunciate to ensure that they're understanding me. Oh, and maybe to go another step deeper, I should speak in simpler language so that I don't confuse them because I know getting older leads to an increased chance of being confused. So, end quote. I don't think anything that I said there was me intentionally trying to be mean toward this hypothetical person. I think it was positive. It was well intended. But it's the underlying message that we're talking about here. What are we saying when we're engaging in a behavior like this? Well, what we're doing is we're exhibiting a behavior, this elder speak that was uh, really initiated by a set of assumptions that were made, which were informed by stereotypes that have largely probably stemmed from society rather than fact and research. And the more and more we engage in these behaviors, the more habitual they become. And and we'll see in some of the research that we've done that if the receiving end doesn't do anything about being spoken to in this way, what's going to stop that provider, that person at the checkout counter from continuing to speak like that? Probably nothing. Okay, I'll end on that slide. Next slide, Hannah. Okay. So yeah, so what we're really talking about in the example that I gave was clearly a age-related microaggression. But before we get to that, let's just talk briefly about microaggressions in general. So here we're at the crossroads now of ageism and microaggressions. Microaggressions, interestingly, have been around for nearly as long. The idea, the concept has been around for nearly as long as ageism. Um, and this was his name was Chester Pierce, also an American psychiatrist, and he defined microaggressions, and this was in a book chapter actually that he wrote in 1970, and then published his first article in 1977 actually. And that article looked at microaggressions targeting Black Americans in TV commercials. Anyways, history lesson. Dr. Pierce defined microaggressions, as you can see in that first line there, covert and subtle manifestations of racism that occur in everyday life. Something that's interesting, in my opinion, is that not much happened with microaggressions from that point until the early 2000s. Um, Dr. Sue, Daryl Wing Sue, a Columbia University professor, really started a line of research that defined racial microaggressions, and that was in 2007. And that paper specifically has been cited thousands of times since it was published. I'd encourage all of you to take a look at that article. It can, I'm pretty sure, be freely found online. Um, it's an easy read, provides a nice primer on racial microaggressions, which are definitely relevant, I think, to this presentation, considering that in the 2020 census, over a quarter of older adults self-identified as being a racial minority. So intersectionality is another area that needs to have a little bit more done on in terms of the intersection of different types of microaggressions as individuals age. I'll get off that soapbox now. Um, Anyways, Sue's definition states, you can see here, I kind of broke it up. Microaggressions are commonly unconscious, not always, but they're day-to-day interactions that can be verbal, they can be behavioral, they can even be environmental, but they communicate hostility. Um, uh, Hostile, derogatory, negative messages based solely on group membership. Um, a nice, concise definition, in my opinion. And we've really seen an explosion of literature discussing microaggressions with other marginalized groups, such as people with disabilities, gender minorities, sexual minorities, religious minorities, and people living in low socioeconomic status. So the the framework has been laid that microaggressions can be translated to marginalized groups, other groups. Next slide, Hannah. So like ageism, microaggressions also have negative impacts. Um, the research suggests that the negative impacts of being on the receiving end of microaggressions, they find that people will experience a sense of like an attacked self-esteem, an attacked belief system, and even an attacked identity. Emotionally, individuals will commonly state things like they felt angry as a result, they felt offended, and they felt sad. So kind of a wide range of different negative emotion as being a victim of a microaggression. Stress, anxiety, confusion, symptoms of depression, feeling almost hypervigilant, um, disengaging behaviorally or engaging in active avoidance have also been noted in the literature. Some research has even investigated whether like the continual experience of microaggressions could be classified under other specified trauma and stressor related disorder. And what I think is interesting of that is if you read some of Dr. Sue's writings, you'll often see he'll state it's like death by 1,000 cuts. Not one cut will kill me, but experiencing microaggressions over and over and over, 1,000 cuts, that could really be pretty detrimental to my health. So, next slide. Okay, perfect. One other thing that I should mention is that many negative consequences have been examined in a multitude of minority groups, like I was describing. However, that research on the previous slide has not been validated to have the same consequences in older adults at this time. We're not there yet with the research. I do feel like that research is probably coming in the future, but just want to state that those negative consequences have not been studied in older adults. Those are a result of microaggressions in other minoritized groups. Okay, microaggression research. Dr. Sue and his kind of co-partner here, Lisa Spannerman, released the second actually edition of their book, like Microaggressions in Life or Microaggressions in Everyday Life. Good book, new book. I'd highly recommend it. It's a really good read for insights into microaggressions, the current state of the literature, and where we can go from where we're at right now. But in their book, they state that microaggressions can be expressed toward any marginalized group in our society. And we've seen, like I mentioned, a major expansion, and you can see some more of those expanding literature areas on the slide here. But we can certainly say that older adults are a marginalized group of individuals, at least in the United States and lots of other areas across the world. But there's continued to really be no research until only a few years ago on microaggressions related to older adults. And Hannah will go through some of the details in the line of research in a bit here. But next slide. Okay. Couple calls to action to further support the need for this. Uh, the expanse of literature, the expansion of literature on ageism has been charged to researchers in the use of qualitative observational methods to examine how ageism really is experienced by older adults today. So here's one quote with a call to action. And then the American Psychological Association also released this resolution on ageism in 2020, where they pointed out pretty pointedly that age truly is a significant risk factor for being a victim of discrimination. And they go on to highly encourage education about ageism interventions and research about interventions to combat ageism. But it's hard to develop an intervention when the concept hasn't, in my opinion, in our opinion, been fully fleshed out yet, which we're hypothesizing is the case due to the lack of research on ageism that is occurring at the micro level, day-to-day basis. There is some research, don't get me wrong, but compared to the macro level ageism, it's lacking. So we need to understand this micro level form in the form of age-related microaggressions. So I think at this point is the next slide. Getting into the research, Hannah, I want to say it is. If so, yeah, perfect. I think I'll pass the baton over to you if you don't mind.
Yeah. All right. Well, thank you everybody for joining today. Like Luke said, it's really exciting to see so many people interested in learning more about age-related microaggressions. I just want to give a quick disclaimer. I keep getting the notification that my internet is unstable. So if I cut out and you miss something that I say, feel free to put that, or please put it in the chat, or unmute yourself and let me know so I can repeat what you might have missed. So I'm gonna dive into some of the research that Luke and myself, along with some of our other colleagues, have done in the area of age-related microaggressions. So to date, we've completed 3 studies on the topic. To our knowledge, these are the first 3 studies on age-related microaggressions. So our first study was completed for Luke's master's thesis. And this was a qualitative study which aimed to describe what an age-related microaggression is. After that, I was completing my master's thesis, and I designed a quantitative study that aimed to sharpen our understanding of age-related microaggressions, based upon information that we've already found from Luke's thesis. And then one of our colleagues, Stephanie Pat, for her master's thesis, replicated Luke's initial study with a larger sample to strengthen our prior descriptions of age-related microaggressions and to strengthen the generalizability of our findings. So I'm going to go a little bit more into depth into each of these studies. And please feel free to interrupt and ask any questions along the way if you have any. So first, we'll start by talking about that initial study. For this study, participants were asked if they've experienced an interaction that was discriminatory due to their age. If they said yes, they have experienced that, they were given the opportunity to provide 3 examples which they were the victim of interpersonal age-related discrimination. This was all questions were asked in an open-ended format. So they were asked when this happened, what their relationship to the perpetrator was, where did it happen, how they felt, and what the intensity to this reaction was, what they felt like the perceived intent of the perpetrator or deliverer of the microaggression was, how they responded to this interaction, and how often do interactions like this happen. They were also given the opportunity to describe another experience that they've heard about, but they weren't the direct victim of that interaction. So for this study, we had a sample of 51 participants that were 65 plus. There were 68% female participants and a majority white or Caucasian sample. So looking at the types of microaggressions reported, micro-insults were the most commonly reported type of age-related microaggression. So microaggressions can be broken down into 3 forms. Those are micro-invalidations, micro-assaults, and micro-insults. Micro-insults are a reminder that, or it's like a demeaning an older adult their identity as being an older adult. Microassaults are those conscious, explicit statements or actions of ageist beliefs, and then microinvalidations are like minimizations of an older adult's experience as an older person. So microinsults were by far the most commonly reported types of age-related microaggressions in this study. We also created a taxonomy of age-related microaggressions. So we took the examples reported and we kind of broke them down into different categories using a thematic analysis. So we were able to break down the types of examples reported into 5 different types of micro insults, 3 different types of micro assaults, and 3 different types of micro invalidations. This is imitating a taxonomy that Sue and his colleagues created of racial microaggressions. So part of the study, or part of our reason for designing this study is we were curious if age-related microaggressions would fit into a similar sort of taxonomy as racial microaggressions. We also looked at the frequency of microaggressions. So when older adults had experienced an age-related microaggression, we asked how often they experience examples or interactions similar to this. So most often, older adults reported experiencing the examples that they reported 1 to 2 times per month. So that really highlights just how often these kinds of examples are happening. Some other results from this initial study, like I mentioned previously, we found that age-related microaggressions can be broken down into a similar fashion to racial microaggressions identified by Sue et al. We also found that older adults experience these interactions fairly often. They feel angry following these interactions, and they respond by passively coping. So just to break this down a little bit, we looked at passive coping, direct confrontation, and a passive aggressive response. So passively coping would be walking away from the deliverer rather than like directly confronting them, which would be the direct confrontation. So telling them that what they did was hurtful or discriminatory or whatever it may be. Whereas the passive aggressive response would be if the deliverer of the microaggression was say a stores clerk, the older adult would be going to the manager and telling the manager what the stores clerk did was wrong. Let's see. So we also found that older adults have a moderately strong emotional reaction. So we asked them to rate how strong their emotional reaction was. In regards to who was delivering these microaggressions, most often older adults reported that the perpetrators were a service provider or a stranger, so both people that the older adult's unfamiliar with. And these interactions were most often occurring in public at a store or a restaurant. Interestingly, we also asked if they felt that the interaction was on purpose or if it was accidental. And most often, the older adults reported that they felt that these interactions were occurring on purpose. So that brings us to our next study. So for this study, we made a few changes to our approach. So instead of using the term perpetrator, we decided to move towards deliverer. That is to highlight the fact that not all microaggressions are delivered, or yeah, not delivered on purpose. So that gets at the intentionality. While older adults may feel that they're being delivered intentionally, it's not clear if the deliverer of the microaggression is always intending to send that message. So for this study, we completed an online questionnaire, which included 20 items that were the most commonly reported examples from our prior study. If they had experienced the microaggression, they were asked how often they experienced this microaggression, the perceived cause for this microaggression being delivered. So we wanted to get an understanding of whether the older adult felt that like the interaction was due to their age or if it was due to another piece of their identity, like their sex, their race, disability, any other forms of identity. We also asked about their relationship to the deliverer once again. We asked about the setting which the interaction occurred, their emotional response to the interaction, and then once again, their behavioral reaction to the interaction. I was also curious about whether or not, or I guess I was curious about what characteristics might influence an older adult um, to feel more negatively following these interactions. So I included questions about physical health, concerns about memory, and then the positive and negative affect schedule um, to determine what characteristics may put an older adult at risk for responding more negatively to these interactions. So for this sample, we had a total of 200 participants who were 65 or above. Ages ranged from 65 to 93, with that mean right at about 70 years old. Once again, our sample was primarily female and white or Caucasian. We did ask about whether or not participants had been diagnosed with a memory impairment, just because we're asking them to think back on previous social interactions that we've had, and we didn't want potential diagnosed memory impairment to be a confound. So those individuals were disqualified from the survey. So we broke down the frequency of experiencing these microaggressions by different types. So surprisingly, a lot of participants reported never experiencing these microaggressions. If they had experienced them, they reported experiencing them about once a year or 3 to 4 times a year, so a lot less frequently than what we found in the prior study. Some other results from this study, as we determined that participants reported having these experiences most often in stores, restaurant or bars, and healthcare settings, so very similar to the last study. Once again, these interactions were delivered most often by a stranger or a service provider. When looking at participants' emotional response to these different forms of age-related microaggressions, they most often responded negatively to micro assaults, followed by micro invalidations and micro insults. So interestingly, we found that for some of the examples, like one of the examples that comes to mind is having the door held open for you. A lot of older adults responded positively to that, and there was a small subset of individuals who responded negatively to that. So that discrepancy between how these interactions are interpreted is something that needs to be followed up on in future studies. Then looking at the behavioral response to age-related microaggressions, participants most often chose to do nothing. So as opposed to that passive coping, the did nothing suggests that the older adult didn't view this as a microaggression and therefore didn't really respond. They just went about their day unbothered. So we then conducted a survey item analysis. We just arbitrarily chose some criteria to determine which of our examples were the most impactful or the most commonly reported and negatively responded to examples from our survey. The criteria we set was having a survey item that was endorsed by at least half of the participants and having more than 1/3 of participants report experiencing negative emotional reactions associated with the item. So 2 of our 20 items met criteria for this. Interestingly, they were both micro invalidations. So the first was being told that your medical issues, for example, arthritis or diabetes, or physical issues, for example, poor eyesight or hearing, are not bad because they're expected at your age. And the second was being told that you do not qualify for a survey after entering your age. Something to note of this second item is it should be noted that because this was an online survey using Prolific, which uses a survey pool, we're getting our participants participate in a lot of other online surveys, so this likely wouldn't show up if we used different forms of sampling. But this first item 12, I think would be something that would show up if we used in-person interviewing or other types of sampling. So looking at the correlates of negative emotional responses, we found that there was a significant correlation between high scores on the negative affect subscale of the PANAS and the frequency of negative emotional responses. So this was a positive correlation. So higher levels of negative affect was correlated with a higher frequency of negative emotional responses. Similarly, we found a significant correlation of perceived physical health. So we had participants report their physical health on a scale of 1 to 5. And we found that the lower older adults reported their physical health, the more likely they were to respond negatively to an age-related microaggression. So that brings us to our third and final study. For this study, it was a replication of the first study that we had described. There were a few changes. So instead of asking if they've experienced experience of discrimination due to their age, they were asked instead if they've experienced an interaction in your day-to-day lives where you felt like you were treated differently because of your age. If they indicated that they had, they were asked in much detail as possible, describe what was said or done by the individuals. And like the initial study, they were given the opportunity to provide up to 3 examples where they were the recipient of one of these interactions. Participants in this sample, once again, were 65 years or older. We had 303 total participants. Once again, ages ranged from 65 to 98, just around that 70, that mean being around 70 years old. Again, primarily female and white or Caucasian sample, though we did have 2 transgender participants. And again, 2 participants were diagnosed with a memory impairment, so they were disqualified from this survey. Looking at the types of microaggressions reported, once again, micro-insults were by far the most commonly reported type of age-related microaggression. And surprisingly, participants most often reported experiencing these interactions every single day. Some other results from this study was participants reported having these interactions most often in retail settings, work, or at home. Most often these interactions, once again, were delivered by a stranger or a service provider. They often responded negatively to these interactions, and they most often responded by passively coping or directly confronting. So 2 opposite ends of the spectrum there. When they were asked about the intentionality of the age-related microaggression, they felt that these microaggressions were committed on purpose. And something added to this survey was they were asked how bothersome or what part of the microaggression was the most bothersome. So in this study, participants reported that they felt like the most bothersome piece was how it was said as opposed to the words that were actually said. So looking at a summary of the results from all of these 3 studies, in general, older adults report experiencing micro insults the most. However, they don't always respond negatively to these interactions. We observed a difference in frequency and emotional responses between the first and third study, and then that second study, and we hypothesized that's due to the method of reporting. So participants are most likely to free recall events which are connected to an in negative emotional reactions. So those are more salient um, to them, um, or ones that occur more often. There exists a correlation between perceived physical health and like levels of negative affect with frequency of negative reactions to age-related microaggressions. And future studies should aim to determine if this relationship is directional and aim to identify other individual difference variables of importance. Lastly, and I think the most important point is microaggressions are most often delivered by strangers or service providers. So this really emphasizes the importance of educating the community on the impact of age-related microaggressions. And then for moving forward for our studies, we hope to complete a focus group study to gain depth in the understanding of age-related microaggressions. We would also like to create and validate an age-related microaggression study so we can really understand how often age-related microaggressions are occurring and what exactly they look like. And because our samples were not representative, we would like to use more representative samples in the future to understand how intersectionality impacts the perception of age-related microaggression. So it's hypothesized that older adults who are a part of different marginalized groups might be less sensitive to age-related microaggressions because they have been experiencing different forms of discrimination throughout their entire lives, rather than someone who is not a part of any other marginalized groups. And this is something that's new for them as they progress into to older adulthood. With that, I will pass it back over to Luke, and he'll be going over some case studies for you guys.
Yeah, thanks, Hannah. That was a nice overview of the work that we've put in to investigating some of this, and hopefully gives you guys an idea of where we're hoping to go in further defining um, age-related microaggressions. I know we have about 10 minutes left, so we didn't leave as much time as I think we were hoping, which is probably my fault for talking too much. But let's, Hannah, go to that first case study. This was probably the most maybe obvious example. So let's just start here. Let's get through this one. So I'll read it. Um, and while I read it, just think about what some of the underlying tones are. What's the message being sent, and how might this older adult be feeling? What might you do different? Um, I don't have a lot of targeted questions with this. I want it to be more of kind of a reflection after talking about what these age-related microaggressions are and what the potential ramifications are of them. So just reflect on it. Reflect whether you've seen anything like this in your experience. Of course, you'll have to extrapolate a little bit, and whether you've maybe done something like this in your life. I know I've for sure committed an age-related microaggression many times. But anyways, okay. First case, we've got Dr. Jameson, a 38-year-old internal med physician. We've got Mr. Thompson, 72-year-old retired teacher, and Miss Carla, 45-year-old nurse. So the scenario is Mr. Thompson arrives for his annual physical, generally in good health, takes daily walks, manages his own finances, and lives independently. Um, Upon entering the patient room, Dr. Jameson loudly knocks, slowly opens the door, and says in a loud voice, "Knock, knock. Don't want to scare anyone. It's been a while, young man. Boy, you're looking good." Um, as Dr. Jameson reviews Mr. Thompson's chart, he chuckles lightly and says, "Well, at your age, it's impressive you're still getting out for daily walks. Most people your age are really slowing way down." As the uh, patient encounter continues, they're talking about the flu vaccine, and Dr. Jameson states, "Well, it might be hard to remember when to come in to get that flu vaccine, so we'll make sure that the nurse writes it down for you." And Mr. Thompson then asks a question a little bit later about this new cholesterol medication that he sees on TV. And Dr. Jameson replies, "Yeah, that's a newer drug, lots of commercials these days." But let's not worry about that. High cholesterol, it's kind of expected for your age. And throughout the appointment, Dr. Jameson refers to Mr. Thompson as young man in a patronizing tone, speaks slowly and loudly, even though Mr. Thompson shows no external signs of hearing difficulty. And then after the visit, Miss Carla, the nurse, walks Mr. Thompson to the waiting room, despite clear signage toward the waiting room. And she says, yeah, these hallways can be pretty confusing. And then she says, oh, and here's that appointment reminder. I'll tuck it in your coat pocket. And Mr. Thompson then called patient relations later that afternoon to complain about how he was treated like a child at his visit. Um, Feel free to unmute, provide any reflections right in the chat. Anything is good to go. I know I've seen particularly the walking of older adults out of the clinic. Um, just to me really has this underlying assumption that older adults are dependent. They need help in some way, shape, or form. Just because you see that they're a 72-year-old on the patient chart, or you look at the individual and you make this automatic assumption that, oh, they look like an older adult, so I'm going to assume this, that, or another thing, and therefore behave in this way or that way. Um, but yeah, totally. Automatically talking slow and loud, that clear example of elder speak that we see so often. Anything else that comes to mind? Yeah, for your age, exactly. We hear that all the time, and that's not totally uncommon for your age. But young man, yeah, absolutely. Definitely, yeah, I would thank you, Lori, for pointing that out. I was just gonna say that definitely a missed opportunity to discuss a new medication. It'd be interesting to see how an encounter like that would go with a 40-year-old patient that's bringing up a new medication. To me, it would be, oh, this person's pretty on top of his game. He's keeping up with the current medications. I better keep up with it and make sure maybe to let the patient lead me to what they might want rather than taking over in a more paternalistic style, prescribing what I think is best. So very good. Um, Okay, question. Can it be difficult to determine when efforts are to be courteous versus insulting? Absolutely. This is probably the hardest part of any of this research. Like Hannah kind of alluded to, it's hard to predict what the mismatch between intent and what is received. Is it going to be negative? Is it going to be positive? It's hard to predict, and that's part of what we tried to do in that second study is look at some attributes that might predict how people interpret. um, and we need to really do more, I think, in that area to see what personal attributes of an individual might predict what the outcomes would be. But I challenge you to think about um, the question further and just think about how could you, if let's try to think of an example. Holding the door. I kind of like that example that you provided, Hannah, because I think we can all relate to it. Um, Rather than just holding the door for an individual, an older adult, which largely a courteous act, right? Um, Perhaps asking the question, "Can I get the door for you?" And let the older adult, let the individual make the decision of whether or not they need assistance, rather than assume they do need assistance with getting the door. Okay, we got 3 minutes left. Let's go to the third case. Skip the second, go to the third. And then, yeah, keep the questions coming in if anybody has any, but I'll run through this one really quick. Miss Rivera, 29-year-old clinical social worker working with a 68-year-old patient who's recently referred for grief counseling and case management following the death of a spouse. She's articulate, independent, history of being highly involved in the community, and arrives for initial intake appointment. This is an example that actually I've seen, and that's what made me write this one. Um, in the case, the licensed social worker printed the intake paperwork um, for this older adult and saying something along the lines, we'll try to make this process as easy as possible. I know technology can be tricky, so I went ahead and I printed the intake forms for you. And then during the intake, Miss Rivera didn't ask any questions related to sexual health, no questions about substance use, no questions about trauma, and decided to complete a formal mental status exam, which the patient did question and saying something along the lines of, "Why exactly are we doing this? I'm here because I miss my," literally interrupted and said, "Is this confusing to you? It's a good idea to get a baseline at your age to see how your mental status is." Um, and when Miss Morgan shares that she's interested in joining a bereavement support group and possibly returning to volunteer work, actually, they responded with, that's great. Staying active is important when people are in their golden years. But let's just focus on one thing at a time so you don't get overwhelmed. Um, they later discussed long-term goals. Ms. Morgan mentioned that she wanted to enroll in an online art history class. And yeah, wow, that's ambitious. Online classes can be a lot, though, especially with all the technology. Have you used Zoom before? A lot of assumptions that occurred here, assuming that there's a potential cognitive issue. So initiating a mental status exam, the assumption that older adults are not sexual, that they don't abuse substances, that this death of a loved one is not leading to trauma, major assumptions about older adults.